Hello, everybody, and we welcome you to our CME program from Total Health titled The New and Supporting Data for Optimizing Therapy in HER2-Positive Breast Cancer. On the behalf of myself, Dr. Tim Soliman from Moffitt Cancer Center and Dr. Jane Meisel from Emory University, we welcome you to this program and we hope that you find it informative and interesting. There have been dramatic improvements in outcomes over time with advancement in HER2-directed therapies. As you can see in this timeline, there's been a dramatic amount of activity and new agents that have been introduced over the decades that have transformed the outcomes and prospects for patients with HER2-positive breast cancer, starting with the advent of trastuzumab in the early 2000s for women with initially metastatic and adjuvant disease, following with the advent of lapatinib and introduction of pertuzumab and TDM1 in later years. We've seen an explosion of options and treatments for patients with HER2-directed therapies that have meant that our patients can expect a higher likelihood of success and cure and higher survival rates too over time with metastatic breast cancer. And this trend is continuing on with the advent of new agents such as tucatinib, trastuzumab deruxtecan, and also with the use of neratinib in various settings, particularly for those with activating HER2 mutations, provide a wealth of opportunities for our patients with HER2-positive breast cancer. And obviously what kicked off a lot of this activity is, as we all are aware of the initial data that was presented and at ASCO many years ago, followed on by the publication of the early stage data as well for trastuzumab, that we were able to see a dramatic improvement in outcomes over time in patients that were treated with trastuzumab. And Dr. Soliman and his group have been instrumental in the introduction of this therapy. And here's just a summary of the data with regards to the outcomes, showing a clinically significant improvement in disease-free survival and overall survival with the addition of Herceptin to standard chemotherapy in the NSABP-B31 trial. And this was a dramatic time when we were able to see this data at the meeting for the first time presented. And this is borne out over years, showing that trastuzumab indeed has been a significant improvement over time for our patients with HER2 early stage breast cancer. So what is the current state of HER2 positive early stage breast cancer treatment? So as I said, patients are doing better and therapeutic advancements have improved outcomes pretty significantly. But we need to emphasize both from the clinician standpoint and also how we speak to our patients about balancing the risk of overtreatment and toxicities with also how to determine whether those agents are truly needed in order to achieve the best outcomes. So it's all about not overtreating or not undertreating patients. Who will benefit from HER2-directed therapies? How do we define HER2 positive disease? It's critical that we accurately identify those patients during our routine care, and it's essential for making informed treatment decisions. And ASCO and the College of Pathologists as well have developed guidelines for standardizing testing for HER2 positive disease. And this is for people that want to reference some of these guidelines here as well. We've cited the key efforts by Dr. Antonio Wolf and his group that has been published in JCO. And it's critical because we know that up to 18% of patients that were tested for their HER2 status in local labs were discordant with the results that were obtained from central testing in the NSABP-31. And so this led to an effort to try to standardize our approach in order to reduce that discordance and properly identify patients who would most likely benefit from treatment. And this highlights the need for accurate identification because there was some interesting subset analysis data for patients that were enrolled in B31 that were low HER2 expressors, basically immunohistochemistry 1+ or 2+. And there was a hint of benefit in retrospective analyses, which then led to the development of the B47 study to see if trastuzumab could help patients who were HER2 negative by IHC standards, but we would call them HER2 low. They were 1+ or 2+, on the basis that maybe there was an immune effect that could allow those patients to do better, not necessarily from blocking HER2 therapy, but by recruiting their immune system. But unfortunately, this hypothesis was not borne out, and the data clearly showed that the results were negative and that there was no benefit to the addition of trastuzumab in those patients that were IHC 1+ or 2+. And so another important factor too that we need to move along as well in the discussion is that immunohistochemistry in FISH are clearly important, and they are the cornerstone for selecting patients for HER2-positive therapy. But we know that we may need to pop the hood and look a little bit closer as to what's biologically driving these tumors, because we realize that not all HER2-positive breast cancer are alike. There's significant biologic heterogeneity that exists within that subtype that we call HER2-positive disease, and that these differences in biology can actually have a significant impact in how they respond to HER2-directed therapies. So for example, we know hormone receptor positive versus hormone receptor negative patients have different rates of PCR when they're treated with dual monoclonal antibodies. And also, we know that the intrinsic molecular subtypes, or those that we call HER2 enriched, may be able to better respond to HER2-directed therapies compared to those that may be luminal B patients with molecular subtype testing. And as you can see in this pie chart here, that when you look at the subtypes that are represented within what we call clinically HER2 negative versus those that are clinically HER2 positive, you can see that the HER2 enriched subset in those that are clinically HER2 positive are a majority of the patients. However, we see that there's still the other subtypes represented within the clinical HER2 category, including those that are basal-like, luminal A and luminal B, which suggests that we may need to further refine our understanding of the disease using molecular signatures as well as classic markers that are available to better select patients for treatment. So ultimately, what we need to look at is that it's probably not a one-size-fits-all approach, right? And that we have to look at tailoring our strategy for each specific patient that's presenting to us. Who would be best served with de-escalating therapy strategies? Again, this idea about not under-treating, but we also don't want to over-treat patients unnecessarily. We want to preserve quality of life, spare risk of long-term toxicities, and also reduce the financial toxicity for patients, but not sacrifice long-term outcomes. Could we use chemotherapy-free HER2-based regimens in tumors that are identified to be highly sensitive anti-HER2 agents using these molecular signatures I pointed out earlier? Who needs therapy escalation? Who are those patients that still remain at risk? So we have insights from the Catherine trial, for example, on how we can potentially address that. And we need more biomarker-driven and response-adaptive strategies as well to make informed decisions about how to make those adjustments. And then we do have remaining unmet needs and challenges. For example, CNS relapse was observed in the Catherine study as a significant issue. And we have data from EXTENET and upcoming studies that may help address that gap as well. So let's speak a little bit about the state of affairs within neoadjuvant therapy for HER2-positive disease. As we have seen through multiple publications, from I-SPY, for example, we have Laura Esserman's group showing that PCR is an important predictor of long-term outcomes, particularly in those aggressive tumor subtypes such as triple-negative breast cancer or the basal subtype, or HER2-positive or HER2-enriched disease. Whereas you can see clearly that patients that attain a PCR do better than those that have residual disease after neoadjuvant therapy. And this is also borne out in other analyses too, such as from the FDA with Dr. Cortazar and their group, showing that this, again, is a predictor on an individual level for an improved outcome in patients that get a PCR from their preoperative therapy. So then, who should be considered for neoadjuvant therapy for HER2-positive breast cancer? How do we pick those patients that are appropriate for that strategy? These clinical guidelines that were published in JCO earlier this year provide some clarity as to those recommendations for who are the optimal candidates. And this mirrors our practice as well at Moffitt and at many centers around the country. And that it suggested that patients that have lymph node positive disease or high risk lymph node negative disease, usually those tumors that are at least 2 centimeters or greater, stage 2 or higher, are probably those patients that would best benefit from a neoadjuvant therapy approach in order to allow us to properly escalate therapy in the adjuvant setting as appropriate based on PCR status. Now, some of the data supporting the use of neoadjuvant therapy and our current practice, particularly using dual antibody therapy with trastuzumab and pertuzumab, which is a dimerization inhibitor that further augments the activity of trastuzumab, was generated from two small studies. The first one we'll discuss here is Neosphere, which was basically looking at combinations of pertuzumab and trastuzumab given in combination with chemotherapy in 3 arms, docetaxel, and 1 arm was just the dual antibody alone, followed by surgery. And all patients received some form of adjuvant treatment, either with FEC chemotherapy or with FEC and docetaxel in the monoclonal antibody arm alone. And as you can see, the primary endpoint here, PCR, was greatly improved with the use of the dual antibody approach plus chemotherapy, with a PCR rate of approximately 45% compared to other arms showing response rates between 16% and 29%. And as was pointed out earlier in the talk, there were fewer PCRs in the hormone receptor positive than hormone receptor negative groups, reflecting this difference in underlying biology. Now, the trial was not powered to look at long-term outcomes. However, in terms of secondary endpoints and analyses, the second group here, group B, that got docetaxel with dual antibodies, did have a numerically superior progression-free survival and also overall survival, which supported this approach of using chemotherapy plus dual antibody therapy in the neoadjuvant setting, and has kind of informed our use of these agents in the preoperative setting. Second trial to point out, Trifena, another phase 2 study, which was primarily looking at cardiac safety of these agents in the neoadjuvant setting, looked at women with early stage HER2 breast cancer and randomized them to get FEC with 3 cycles plus the dual antibodies, followed by docetaxel for 3 cycles plus the dual antibodies, so-called concurrent approach with anthracyclines, versus a sequential approach where we looked at FEC-D given for 3 cycles alone, then giving docetaxel for 3 cycles plus the dual antibodies. And then you have this TCHP times 6 arm, followed by surgery, and then adjuvant trastuzumab, as we would typically do for a total of a year. And like I said, the primary endpoint is cardiac safety, secondary endpoint was PCR. And in this arm as well, when you looked at the use of the agents here, interestingly, the arm that had the highest numeric PCR rate was the TCHP arm, which is the agent that we use predominantly at our center and has become a standard option for treatment of women with HER2 positive early stage breast cancer in the neoadjuvant setting. And that's been a standard approach overall. And also, it should be noted that the doses and the FEC-D combinations were a little bit different than what classically was given with regards to FEC. But the idea is that ultimately, one question that comes up, because another common regimen that was typically in use is sequential AC followed by THP, which is again felt to have been an acceptable regimen based on historical and other data showing that Adriamycin is important for HER2 positive breast cancer. Our investigators from the MOVE group performed a trial known as TRAIN2, which looked at the role of anthracyclines in early stage HER2 positive breast cancer. And here you can see the design of the study, which took stage 2 to 3 HER2 positive breast cancer patients and randomized them to either get anthracyclines as part of their treatment, which was the FEC regimen every 3 weeks for 3 cycles, followed by carboplatin and paclitaxel every 3 weeks for 6 cycles, with trastuzumab, pertuzumab added in, versus a non-anthracycline group, which had carboplatin, paclitaxel every 3 weeks for 9 cycles, with trastuzumab and pertuzumab every 3 weeks. And then the patients proceeded with surgery and standard adjuvant therapy, as would be indicated. And the primary endpoint of the study was PCR. And here you can see that the PCR rates were similar between the 2 groups. So there was no significant advantage in the primary endpoint for the addition of anthracycline to patients that were treated. And this enforces the idea that the key improvement in PCR rates in this day and age is the use of dual monoclonal antibody, and that de-emphasizes the role of anthracyclines in this population. And also, there was a significant difference in the events that were noted from a cardiac standpoint with using anthracyclines as well. And so even though long-term outcomes appeared to be equivalent in both arms, you had a higher number of left ventricular ejection fraction declines that were clinically significant in the anthracycline arm at 8.6% versus 3.2% in the non-anthracycline arm. And so this trial has been informative, particularly reinforces our practice at our center that we predominantly use TCHP for most of our patients with HER2 positive breast cancer in the early setting. Now, some interesting new data that was just presented by Nadia Harbeck on behalf of our investigators from West German study group looked at the ADAPT study, which is a multi-arm, very large design looking at various questions for patients with early stage disease. In this particular part of the study, they're looking at the HER2 positive space with a primary question of whether they can de-escalate therapy appropriately. And in this study design, they took women with early stage disease that were HER2 positive, and they were ER negative and PR negative, and randomized them to either get trastuzumab, pertuzumab alone for 12 weeks preoperatively, or get trastuzumab, pertuzumab, and paclitaxel preoperatively. And then they would get surgery and look at PCR rates. And there was a number of correlatives that were incorporated in the study that they're continuing to present data on. And some of that was revealed at the presentation at ASCO this year. So when you can see the data here, clearly the PCR rates were increased in the group that received paclitaxel in combination with both antibodies. This was reflected in both the data that was showing those patients that had both definitions of PCR, either allowing in situ disease or not, which is reflected in the blue or in the green bars here, clearly favoring the chemotherapy arm here. But however, I think an interesting piece of data to note, the 5-year disease-free survival rates for this group were excellent, with a 98% 5-year disease-free survival for those patients that got paclitaxel and trastuzumab and pertuzumab. And then also, when you look here at the second curve, though, what's revealing is that it shows that patients that attain a PCR, even in arm A that did not get chemotherapy, had an excellent 5-year disease-free survival at 98%. And this reinforces the idea that patients that achieve a PCR likely will do well, irrespective of the regimen that was used to get them there. And so I think this brings up an interesting question that we need to look at is, can we better identify those patients that are appropriate for de-escalation? And they touched upon this a little bit at the presentation by using some of these molecular markers as well. And so stay tuned to that story. But for now, the standard would be using chemotherapy with pertuzumab and Herceptin. But it does allow us to question whether we need TCHP, for example, in all those patients, and can we potentially use this less toxic regimen with similar excellent results. And so now I'd like to move on to talk about adjuvant therapy. And this is an important setting as well, because not every patient necessarily coming in the door will get neoadjuvant therapy, and we need to understand how to best treat our patients in the adjuvant setting. And so we'll go over data from Affinity, which speaks to this, also data on Catherine in terms of escalating treatment, and then also touch upon the extant data as well with the use of neratinib in the appropriate setting. So what about the role of pertuzumab in the adjuvant setting? Well, Affinity was the trial that was designed to look at that, and it's a phase 3 trial of adjuvant pertuzumab that was added to trastuzumab in resected HER2 positive breast cancer. And there had been some design changes over the years in the conduct of the study. However, they took women that were HER2 positive disease, that were node positive, node negative, but the tumor had to be over 1 centimeter, at least initially, and the study was open, and have good cardiac function. They're randomized 1-to-1. They get standard chemotherapy plus trastuzumab with placebo, or with the same treatment that was decided by the physician with the addition of pertuzumab. And the primary endpoint was invasive disease-free survival, with secondary endpoints with overall survival and disease-free survival, and some other issues around quality of life and safety. And when you look at the data overall, in terms of the data was statistically significant and positive, showing an improvement in outcomes for patients that had pertuzumab added to adjuvant trastuzumab therapy, showing that there was a numeric and statistically significant decrease in invasive disease-free events with the addition of pertuzumab here. Now, that being said, when you look at the 3-year IDFS data initially when it was presented, the difference was approximately 0.9% for the intent to treat populations. And again, people have kind of asked how significant is this benefit overall, right? And then we've looked at trying to understand, well, where do those patients truly benefit from the treatment? in order for us to maximize the risk versus benefit ratio of applying this. And over time, what has been borne out predominantly is that it looks like those patients with higher stage disease, particularly the lymph node positive subset, were more likely to derive a numerically higher benefit from the addition of pertuzumab. And if you look at here at the hazard ratios over time, here they had the number of positive nodes being 1 to 3 or N1 disease versus those that would be considered N2 disease, had similar hazard ratio reductions with the addition of pertuzumab. The delta did increase though for those that had more lymph nodes positive to 2.8% compared to the intent to treat analysis of 0.9%. And earlier too, there was some suggestion that the hormone receptor negative subtype may derive a larger benefit as well compared to those that are hormone receptor positive, which makes sense because there is adjuvant endocrine therapy that can be added for some of these patients as well, may further reduce the risk. However, over time, this analysis has been updated to show that there likely is benefit in both subsets, but that it still predominantly appears to be in the lymph node positive group that derives the most benefit. So we can try to tailor our approach that way to focusing on that group when we want to add pertuzumab in the adjuvant setting. And this is again just showing with the updated data and analysis here that this difference does hold up over time. So at the 6-year IDFS and the intent to treat, this difference does hold up with a delta of 2.8% between the two groups as well. And then this lymph node positive subset, as I mentioned, is predominantly here showing that this increase is at 4.5%, right? So this updated data reinforces the strategy that was discussed earlier, saying that we should probably focus on higher stage disease as the patients that we would add pertuzumab to if we encounter them in the adjuvant setting. And looking at the hormone receptor positive versus negative group, initially, while the early data thought that there was a difference, here you can see that, again, there appeared to be a difference between both groups, slightly favoring those patients as well, again, in both scenarios, suggesting that, again, we probably shouldn't use this as the cutoff for deciding benefit, but focus more on the node status. Now, one of the issues that we'll discuss and touch upon in this study and others is that pertuzumab did reduce distant recurrence, but unfortunately did not appear to have an effect on CNS recurrence rates as the site of first recurrence, with equal events, which were rare. It was 2% in both groups. Fortunately for patients, because we know it's a devastating event when it does occur that can be difficult to treat. And so this does reflect, though, that even for this subset of patients, we need to do better and we need to introduce additional therapies that can further mitigate this risk of CNS relapse. So then looking at TDM1 therapy as a method of trying to escalate treatment. So in those patients that have gone through neoadjuvant treatment but have residual disease, and as you are aware, TDM1 is an antibody drug conjugate that is trastuzumab that has enhancing a mysanthine derivative microtubule inhibitor that's very potent linked to it. And basically, so it's like a smart bomb of chemotherapy that's precisely delivered to cells with HER2 overexpression on the surface and binds with similar affinity to trastuzumab. And so Catherine was a study looking at the use of TDM1 in residual disease patients that had gone through neoadjuvant therapy. So they were T1, T4, could have been node negative, node positive, and they had to be HER2 positive. Underwent standard neoadjuvant therapy, and then were noted to have residual invasive disease, and that was any residual disease that was noted. Randomized either get TDM1 for 14 cycles or trastuzumab adjuvant, as was the practice when the design of the study was implemented. And the primary endpoint was invasive disease-free survival. And here's just a summary of the patient characteristics that were well balanced. And you can see here too that there was a predominance of ER positive disease in this group, suggesting that they are more likely to have residual disease, as we pointed out earlier too. And then if you look at the numbers that received dual therapy, it was balanced in both arms at about 18%. So they were the minority at that time. Most got trastuzumab alone. And here are the efficacy outcomes showing that TDM1 significantly reduced the risk of an invasive disease-free survival event with 88% of the patients who got TDM1 disease-free at 3 years versus 77% with trastuzumab alone. As well, if you look at distant recurrence as the first event here in the second curve, again, 89.7% were free from the distant event with TDM1 versus 83% with trastuzumab alone. And this led to the indication that we use it currently for in the adjuvant setting for patients with residual disease and has widely been adopted here in the US. Now, again, overall survival did not cross the early reporting boundary, and it's something that we need to continue to follow over time because of the relatively small number of events that were observed, 42 in the TDM1 and 56 in the trastuzumab arm as well. And so this data needs to mature over time in order for us to look at any overall survival advantage. And within the subgroups here, there was consistent benefit favoring TDM1 across all the subsets, including those that were ER negative and ER positive, and those that were node positive versus node negative. So all of the subsets were favored to use TDM1. However, again, we see this persistent and stubborn issue in CNS recurrences. Even with these improved outcomes, we still saw approximately 6% in the TDM1 and about 5% in the Herceptin alone arm have CNS recurrences. And so this brings up the question, what can we do to further address this problem? And the safety overall was acceptable and was in keeping with our understanding of both agents. And I don't think there was any kind of major signals there that emerged from the trial. And also here is because it's in the adjuvant setting, often radiation is administered appropriately for these patients with node positive disease, for example. And the rates of radiation-related skin injuries were not significantly different between the groups. There was a slightly increased risk of peripheral sensory neuropathy in TDM1, as we would expect, but it was not unmanageable or excessive. So then moving on here too, to look at de-escalation options and how can we best kind of address whether we can continue on with therapy as needed in adjuvant therapy when they're doing well from preoperative treatment, or do we need to increase our intensity in the adjuvant setting? And here I want to point to an interesting ongoing study from ECOG Akron, the COMPASS HER2 trial that shows here that patients with stage 2 or 3 HER2 positive disease are enrolled in the study, and they get some correlative sample collection, and then they're basically treated with THP for 4 cycles with either paclitaxel or docetaxel and dual monoclonal antibody therapy. And then they undergo surgery. And then based on their PCR status here, for the first part of the study with COMPASS, they're just allowed to complete 1 year of HP, get radiation endocrine therapy as indicated, and go on to follow up here. And then also if they don't have a PCR, they're either offered like standard of care therapy with additional chemotherapy and HER2-directed agents per the individual treating physician's discussion, or they can enroll in other studies as well and get follow-up for recurrence. And this is, again, like trying to look at, with the use of THP, as we pointed out in Nadia Harbeck's data, is this an acceptable strategy or approach that could be used to kind of reduce some of that preoperative toxicity, but also use this potential escalation strategy based on PCR status afterwards and see how patients do. Also, another arm here that's being looked at in the no PCR group, and I think everybody's very interested to see how this pans out, is that one of the trials that can be looked at is whether giving TDM1 alone, as we would give per the Catherine study, or TDM1 combined with a TKI tucatinib, which is a HER2-specific tyrosine kinase inhibitor added to TDM1, which may enhance the uptake of TDM1 within the cancer cells, could potentially provide not only an improved anti-cancer activity with an improved disease-free survival, but also may reduce the CNS events, as tucatinib is known to penetrate into the brain and may reduce those CNS events we saw in Catherine. And so we're eagerly awaiting the results of this data when it reports out. Also, another idea is that whether we can use novel agents as well that have been developed, antibody drug conjugates, aside from TDM1. And here we see the use of trastuzumab deruxtecan versus TDM1 in the DESTINY-Breast05 study, looking at high-risk HER2-positive breast cancer patients with residual disease, head-to-head, seeing if the use of trastuzumab deruxtecan can provide additional benefits since it has a different payload than TDM1, which is a topoisomerase 1 inhibitor, SN38, with a higher drug to antibody ratio as well, compared to the drug to antibody ratio 4 that is seen with TDM1, and also can cross over the cell membrane, so it has additional bystander kill effect. And so we're looking to see if this antibody may provide an improved outcome in patients, particularly too because it may have activity in other settings such as those with HER2 low disease, but there may be FISH positive, for example. And so we want to see, again, if we can tease out differences in signal there, and we're very interested to see how this data pans out. So what about HER2 positive directed TKI use in the adjuvant setting? And so here you can see the landscape over time has evolved from the initial use and introduction of lapatinib, followed by neratinib, and then more lately tucatinib. And they have different toxicity profiles and also specificity for targeting the HER family of proteins, with lapatinib having both EGFR and HER2 targeting activity, but it's reversible. Then you have neratinib, which is a very potent, irreversible pan-HER2 tyrosine kinase activity. And then you have tucatinib, which is an oral potent reversible selective HER2 tyrosine kinase inhibitor, which causes less EGFR off-target toxicity, particularly with diarrhea compared to the other two. And so here, we would like to point out some of the interesting updated data from Extenet, which looked at the neratinib for 1 year after the use of trastuzumab in the adjuvant setting for patients with HER2 positive breast cancer. And here you can see stage 1 to 3 patients that were HER2 positive were randomized to either get neratinib for a year after completing standard therapy versus placebo for a year. And we have numerous data and follow-up points here for invasive disease for survival as the primary endpoint, in addition to also looking at overall survival. And the initial data at 2 years was shown that there was indeed a benefit for the use of neratinib, showing an IDFS rate of 93.9% versus 91% for placebo. And this was statistically significant. The benefit was predominantly, though, seen those interestingly with HER2 positive disease that was also hormone receptor positive. When we look at the 5-year follow-up data, this difference held up over time, showing that the 5-year IDFS was 90.2% in neratinib versus 87.7% with a delta of 2.5% over time. And then again, we did observe this difference by hormone receptor status, where the benefit was predominantly seen in hormone receptor positive. And it's an exploratory analysis, but again, it's been informative to help us kind of prioritize the use of this agent, showing that there was a 91.2% benefit in the use of neratinib versus 86.8% in the placebo group with a delta of 4.4. This difference was not seen in the hormone receptor negative group. And then when you look at where the benefit was greatest, and this is also consistent with the label for the use of adjuvant neratinib, particularly in Europe, is those patients that were hormone receptor positive early stage breast cancer and that were within 1 year of their post-trastuzumab treatment. When you look at the descriptive analysis that was performed, again, in the hormone receptor positive group, this difference increased to like 5.1% with an absolute 8-year overall survival benefit of 2.1%. And this is predominantly the indication or the use of the drug as well in Europe, and then also in the US as well for patients that are considered for this therapy. And then when you're looking at as well, interestingly, in terms of patients that were less than 1 year post trastuzumab here, the absolute 5-year disease-free survival increased again to 7.4% with an overall survival advantage benefit of 9.1%, indicating that early initiation of the treatment right after the completion of trastuzumab is likely going to give you a bigger bang for your buck and should be discussed with the patient if you feel that they are appropriate for that line of therapy. Now, when we look at this CNS event that we talked about in Catherine as well earlier, those patients that received neratinib had fewer CNS relapses compared to those in the placebo arm, right? And so this raises that possibility that this strategy appropriately adopted may be able to address some of those CNS events that are stubbornly persistent across some of our escalation studies, such as Catherine, that we observed earlier here too. And we know that, again, one of the key challenges that we have to address with neratinib is that diarrhea was a significant issue with the use of neratinib, and that a key strategy that's emerging that's important for proper use and adoption of neratinib in the setting is to use what's known as the dose escalation approach, and not to start at full dose neratinib, but rather start at a lower dose and escalate a week at a time to the target dose in order to mitigate the severity of the diarrhea and improve patient compliance and prevent dropout over time. And so, again, to summarize, when to consider adjuvant pertuzumab and neratinib. So adjuvant pertuzumab should be considered in eligible patients with larger tumors, those over 2 centimeters, and lymph node positive in particular. That is important as well. And so in either the neoadjuvant setting, we want to look at stage 2 and 3 patients to look at dual antibody therapy. In the adjuvant setting, again, focus on lymph node positive disease. With the longer term follow-up, at least we know that looks like the benefit is holding up in both hormone receptor positive and negative disease. And there really is no data, though, really at the time to determine the role of continuing pertuzumab post-neoadjuvant therapy, though PCR versus non-PCR on that basis. The trial didn't really look at that. And so that's still something that we, again, are leaving to medical judgment to kind of figure out whether we want to continue doing that in appropriate settings. And then with adjuvant neratinib, it's likely those patients that are hormone receptor positive, those that are lymph node positive, and then also those that did not attain a PCR post-neoadjuvant therapy are most likely to benefit from the use of adjuvant neratinib for 1 year after completion of their year of monoclonal antibody use as well. And to get the most benefit, they should start within 1 year of their last dose of completion of their monoclonal antibody. One of the issues is that, again, the role of neratinib post-T-DM1 and pertuzumab is unclear because Extenet was designed prior to the advent and introduction of these agents in the setting. So we don't have that data yet. However, there may be real-world data or other data sources that may give us some information on that over time. And I think there's an exciting role potentially for neratinib to prevent CNS relapse, and we do need to look at that. And again, based on data from the control trial, as I mentioned earlier, I think it's emerging that the dose escalation strategy is the favorite approach in order to optimally use neratinib. And here's just wanted to touch upon as well some ongoing therapy escalation trials in HER2 positive breast cancer. Again, to reiterate that, again, looking at this data over time, these combination approaches of tucatinib and T-DM1 are things that we may see in the future as being a way to be able to properly select the most active drugs to be able to mitigate not only extracranial relapses, but also CNS disease. So what about smaller stage 1 tumors, those that are lymph node negative or under 2 centimeters? So data that was presented from Dana-Farber with Sarah Tolaney and her group of investigators, they performed a phase 2 trial of adjuvant TH, Taxol, and Herceptin for early stage small HER2 positive breast cancer. And these patients could have had tumors under 3 centimeters. They were node negative or had microscopic N1 disease. And basically, it wasn't randomized. It was a single arm study looking at invasive disease-free survival as the primary endpoint. As you can see in intent to treat disease-free survival, the outcomes over time have been excellent, with at the 7-year disease-free survival analysis showing a 93.3% freedom from invasive disease-free recurrence. And it was hard to imagine that we could improve further on the outcomes of these patients. And so this has been widely adopted as a standard adjuvant therapy on the basis of this data for patients with small HER2 positive tumors that have undergone primary resection. And here again, when you look at the update over time, again, the data is held up beautifully and is showing that this is still a very attractive option for many of our patients with small tumors. And this is predominantly because if you look at over time, the toxicity profile has been very manageable. However, one of the key issues that we do observe, though, is that there is still a significant risk of neuropathy, which we know comes from the Taxol and is not unusual. But obviously, it's something that we are looking to see ways that we can mitigate the emergence of neuropathy and use alternative strategies, potentially in these small tumors, to try to stop some of these toxicities over time, which can be persistent. And so this was one of the attempts to do this through the TBCRC33 trial, which was a phase 2 trial of adjuvant TDM1, looking at these small tumors, and they were randomized to either get TDM1 in the adjuvant setting for 17 cycles or TH. And again, co-primary endpoints here that were 3-year IDFS with TDM1, and also to compare the incidence of clinically relevant toxicities between TDM1 versus TH. And at the initial analysis, median follow-up of 3.1 years, TDM1 efficacy rates were similar to historical standard of care of TH in the APT trial, showing a 97.7% 3-year DFS rate with TDM1 versus 93.2 in the TH arm. And again, the event rates were low in both arms, showing an excellent 3-year recurrence-free interval, 99.1%. And again, the attempt was not powered though for comparison of efficacy between the two arms, and they do still need to continue follow-up. However, this provides additional supporting evidence that TDM1 may be an option to use in these early stage patients, particularly if there's a concern around neuropathy. As I highlighted earlier in the prior data, there appeared to be a lower rate of a grade 2 or higher neuropathy with TDM1 compared to the TH group. However, there were toxicities that required early discontinuation at a higher rate in TDM1, particularly some of the non-hematologic toxicities and dose delays that were observed. And so, again, it's not that there were new safety signals from the use of TDM1, right? However, the toxicity profiles were different, okay? And so I think that's one of the issues, that the TDM1 duration that was selected for the trial may lead to increased toxicities. So how do we further de-escalate and potentially use a shorter length of TDM1 treatment and to improve the tolerability while also mitigating toxicities of concern like neuropathy? And that's where some additional work needs to happen in this space in order to try to better optimize the use of TDM1 and reduce the relative toxicity though compared to TH. So for now, we still tend to use a fair amount of TH in our patients and reserve TDM1 for select cases where we may have a concern about neuropathy, counseling our patients about these potential toxicities, right? And that's where a trial like Attempt 2.0 comes in, where again, they're trying to look at, say, 11 cycles in order to kind of improve the tolerability. And again, we're awaiting data on that to see if it improves toxicity. So just to close, in summary, here is kind of our suggested approach for patients with HER2 positive disease. Those with small tumors can go to surgery initially, and then those with small tumors, can get a trastuzumab based approach with Taxol chemotherapy. Those with larger stage tumors, either like T2s or those that are node positive, are more appropriate to get adjuvant therapies with TH or TCHP or TCH, for example, if they're node negative, and then maybe consider neratinib if they have high stage disease, particularly if they're hormone receptor positive. If they have stage 2 or higher disease at presentation, we tend to take them to neoadjuvant therapy, again, in order to ascertain that PCR status, as it's important for escalation or de-escalation post-surgery. And those with residual invasive disease can get TDM1 per the Catherine study and discuss neratinib afterwards, potentially for those with hormone receptor positive disease when appropriate. And if they get PCR, you can then just continue with the monoclonal antibodies. And so as this approach evolves over time, we hopefully will be able to continue to evolve the strategy to incorporate novel agents as appropriate. And so with this, I'd like to conclude my presentation, and I appreciate your attention. And I'd like to turn over the presentation now to my colleague, Dr. Jane Meisel. Thank you for your attention.
So you've heard a lot now from my colleague, Dr. Soliman, a wonderful overview of some of the advances in early stage HER2 positive disease, which we hope will ultimately lead to fewer patients needing these advances for HER2 positive metastatic breast cancer. We've also had some fantastic advances in the past few years in this field, and we'll go through some of these as we conclude our program today. So first, just a little bit of a review, and I won't belabor this too much because we've talked some about this already, but of the different kinds of HER2 targeted therapies. So we have trastuzumab, which is an antibody, and trastuzumab deruxtecan, which is a new drug we'll talk a bit more about, and pertuzumab in the antibody setting. But then we also have a number of other ways to treat HER2 positive metastatic breast cancer. We have small molecule therapy. We'll talk about tucatinib and neratinib and lapatinib and where those fall into our algorithms. And then antibody drug conjugates, You've already heard a bit about TDM1, and then you'll hear some more about DS8201A, which is now FDA approved. And then finally, margetuximab, which looks a little bit at both targeting antibodies and also immune cells, how that may play a role for some of our patients with particular subtypes of HER2 positive breast cancer. So this is just a timeline looking at FDA approvals for HER2 positive disease. And as you can see, trastuzumab was approved in the metastatic setting way back in 1998. And then things were a little bit slower in terms of progress with no further approvals until we got lapatinib in 2007, 2008. But as you can see, in the last 10 years, we've really had an explosion of options for these patients, and really particularly in the last 24 months. We had pertuzumab approved in 2012, which we'll discuss today, then TDM1 in 2013, neratinib approved in the adjuvant setting in 2017, and then later in the metastatic setting. And then finally TDM1 adjuvant in 2019, but also trastuzumab deruxtecan in that setting. And then in 2020, we've had tucatinib, neratinib, and margetuximab added. And I think, particularly in the setting of the COVID-19 pandemic, to have so many options for our patients continuing to be approved, research ongoing, has been really inspirational, not to mention life-altering for many of our patients. As we know, HER2 positive breast cancer, despite all of these advances, remains a high unmet need. This is data from some of the earliest HER2 positive studies where we saw significant advances with the addition of trastuzumab to early stage treatment, but we know that 10-year disease-free survival outcomes are still nowhere close to 100%. And so to help cure more women and help more women live longer, we still need better treatments. And so how do we add to that trastuzumab option? The first thing we did was we looked at Cleopatra. So this is a study that looked at the addition of pertuzumab to trastuzumab plus docetaxel. So older data now, but for those of you who may not be as immersed in it, I think still great for review. These were HER2 positive metastatic patients who were randomized to receive either trastuzumab plus placebo plus docetaxel, or trastuzumab and pertuzumab plus docetaxel. So basically 2 anti-HER2 targeted antibodies as opposed to 1, to see if the combination of the 2 was better than the other. And what we found, as you may have seen these curves before, was that these drugs improve not just progression-free survival, but really importantly, overall survival in the intent to treat population. So the median overall survival in the trastuzumab docetaxel arm was 40.8 months versus 57.1 months, a 16-month improvement in overall survival for the addition of pertuzumab in the first-line metastatic setting. The 8-year landmark analysis showed that 37% of patients were alive with pertuzumab at 8 years, versus 23% of patients with trastuzumab. Again, real, both statistically relevant, but also very clinically relevant options. And this is important because pertuzumab, it adds cost, but it does not add a lot of toxicity. And the idea that adding an agent like this in the upfront setting for metastatic disease could improve not just how long people get until they progress, which is again a very clinically relevant endpoint, but also how long people survive makes a difference. So this clearly was very important for these women and became an addition to the standard of care. And that remains really the standard of care for first-line treatment of metastatic HER2 positive breast cancer today in this country, trastuzumab plus pertuzumab plus chemotherapy. And then what about after that? Because obviously, many of these patients do well on trastuzumab, pertuzumab for a long time, but they still progress. And right around the same time as this study was being done, the Amelia study was going on. And this was looking at TDM1, a novel antibody drug conjugate and the first of its class for HER2 positive breast cancer. You've heard a bit about this data already because much further after Amelia, we had the Catherine trial showing that TDM1 was an effective agent in patients who did not get a complete response in the upfront setting to neoadjuvant HER2-directed therapy. But before the drug was even studied in that setting, it was approved for metastatic disease. So this trial looked at TDM1 single agent every 3 weeks IV versus lapatinib plus capecitabine, which was an appropriate second-line option at the time of this trial. And what they showed was that in the 991 patients who were randomized, progression-free survival was improved by about 3 months in patients who received the TDM1 versus the lapatinib capecitabine, and overall survival was improved as well by about 5 months. So definitely statistically significant and clinically significant outcomes. And TDM1 also was a very well-tolerated drug in the metastatic setting, almost ironically better tolerated in metastatic patients than sometimes we see in upfront patients. But despite improvements in progression-free and overall survival, patients still progress after TDM1. You see this in the curves that, they progress less quickly, but they still progress. So still more options are needed. And one of the most important areas is brain metastases. And Dr. Soliman touched on this a little bit, but I think important to note that breast cancer has the second highest incidence of brain metastases among all cancers. And in patients with HER2 positive breast cancer, the incidence of brain mets can be upward of 50% in the metastatic population. We know that the brain is frequently the first site of relapse in HER2 positive metastatic breast cancer patients. And this is definitely an area that's sort of a high unmet need area, an area where we really need to focus, because now with better systemic treatments, this often it ends up becoming the Achilles heel for many of our breast cancer patients with HER2 positive disease. As we know also from retrospective studies, brain metastases may go undetected in this population. Some of these retrospective trials listed in this table here show that asymptomatic brain mets may occur in up to 15 to 36% of patients with HER2 positive metastatic breast cancer. And so the importance of knowing how to detect these, having a low threshold to suspect these, and also thinking about how might we prevent them and treat them when they occur is really, really important. The Catherine trial, as Dr. Soliman showed, improved outcomes significantly for patients who received TDM1 versus trastuzumab after having a non-PCR to neoadjuvant treatment. But in those who recurred in both arms, 5% of those that recurred had a CNS recurrence as one of the sites of first recurrence. And so, even with the most optimal upfront therapy, CNS recurrence is still a big issue. There are specific NCCN guidelines, as many of you may know, for CNS cancers. And as you can see, the NCCN guidelines actually separate out HER2 positive breast cancer options, because thankfully we do have some options, and really some newer options in the past couple of years for treating patients with HER2 positive brain mets. So we'll talk a little bit more about that now as well. The HER2 CLIMB study may be one that you're familiar with. This was a study that looked at tucatinib, trastuzumab, and capecitabine for previously treated HER2 positive metastatic disease. So these are patients who had progressed after pertuzumab, trastuzumab, and TDM1. So really a classic third line population. They enrolled patients with and without brain metastases, and we'll talk more about the brain metastasis population on this study. And they were enrolled in a 2-to-1 fashion to receive capecitabine, trastuzumab, tucatinib versus capecitabine, trastuzumab, and placebo. So essentially all patients were getting 2 different kinds of pills, capecitabine plus either tucatinib or placebo, and then intravenous trastuzumab every 3 weeks. The primary endpoint was progression-free survival, and then they looked at these outcomes specifically in patients with brain mets and looked at overall survival in all patients. And as you can see here, and I won't belabor this point too much just because I know we're kind of short on time, but tucatinib is a HER2 selective kinase inhibitor. And as Dr. Soliman suggested, may have fewer off-target effects than some of the other EGFR inhibitors that we use in this disease. So this breaks down the HER2 CLIMB patients into their specific characteristics. And we're just going to hone in for a second on the patients with brain metastases, who made up about 48% of the patient population. As you can see here, 40% of the patients with brain mets had stable brain mets. 60% of those had active brain mets. And of those, 23% had untreated progressing brain metastases when they enrolled in the trial. And 37% had brain metastases that had been treated but were progressing. So like those who had received radiation or other local interventions, but still had progressive disease. So this was a sick bunch of patients. As you can see here, also 74% of patients on the trial had visceral metastases. So these patients, definitely needed active treatment. And what was found was that in patients who were treated on this study, progression-free survival and overall survival seemed to be improved by the combination. You see that the progression-free survival was 7.8 months in the tucatinib arm versus 5.6 months in the placebo arm. And then overall survival was improved as well by about 4 months. When you look at disease control rate, this is really an impressive waterfall plot here on the left. You can see that regardless of the presence or absence of brain metastases, patients improved significantly with the combination. The disease control rate was 92% in the tucatinib arm, 85% in the placebo arm. And then if you look at survival benefit in patients who had stable disease as the best response, the overall survival favored the tucatinib arm, with 78% alive at 12 months versus 59% alive at 12 months in the placebo arm. And if you think about the clinical significance as well as the statistical significance of that, it really is impressive to have 78% of patients who go on this regimen alive at 12 months when this is third line treatment is really quite amazing. And then if you look specifically at the brain met population, you can see that the risk of progression or death in patients without brain metastases was reduced by 43% in the total population, with a median progression-free survival of 9.6 months versus 6.8 months. And then in patients with brain metastases, we also see this. So at 12 months, 22% of the patients with brain metastases had not progressed yet, and 70% of those patients were still alive on this regimen. So again, thinking about this from the perspective of the woman who walks into your clinic with HER2 positive metastatic breast cancer in the brain, to be able to start this regimen and let her know, how good her odds are of being alive a year from now are impressive. So this really was a big step forward for patients. You can see here also that looking at it another way, the risk of developing new CNS lesions or dying was also reduced by 48% in all patients with or without brain metastases in the tucatinib arm. So again, helpful for treating brain metastases, maybe helpful for preventing brain metastases. I think this drug, definitely is going to have a role, already does have a role for our patients in the metastatic population, certainly, but we may see it also start to have an impact and gain approvals in other areas. So very promising data. And then another drug, trastuzumab deruxtecan, which many of you have probably heard about and some of you may have used, a new antibody drug conjugate. So this is sort of similar to TDM1 in terms of its makeup. It's a payload, a chemo-like payload attached to a HER2-directed antibody. The differences are that the payload is slightly different. So whereas TDM1 uses a microtubule inhibitor, trastuzumab deruxtecan uses a topoisomerase 1 inhibitor. The drug antibody ratio is a little bit higher with the trastuzumab deruxtecan, a drug antibody ratio of 8 compared to 3.5. So potentially a little bit more potent in terms of how much chemotherapy gets delivered to the cell. And then it's a membrane permeable payload. And so what that may mean, and there's still studies ongoing, is that if there is a heterogeneous sort of clone or area of tumor, then the drug will sort of hone directly to the HER2 overexpressing cell. But if there are less HER2 positive cells surrounding that, then this drug may be able to penetrate those cells as well. So for sort of HER2 heterogeneous, or maybe even HER2 low populations, this may be a helpful agent. DESTINY-Breast01 is the first trial that led to this drug's approval. So there was a part 1, which was a pharmacokinetic and dose finding study, and then a part 2, which was sort of like a phase 2 continuation single arm trial for patients on this drug. And similar to TDM1, it's an IV drug that's given once every 3 weeks. And the total number of patients enrolled at the phase 2 dose was 184. So 184 patients enrolled at the 5.4 milligram per kilogram dose. And if you look at the patient characteristics here, you can see that there are a number of different things on the list, but the main thing I want to draw your attention to is the fact that the median prior lines of treatment for these patients was 6. So many of these patients had received a fair amount of prior treatment. This ranged from 2 to an amazing 27 median lines of prior treatment, but this was a very heavily pretreated patient population. 91% had visceral disease. Only 13% had a history of brain metastases, but we'll get to the brain met patients in this trial a little bit later on. So a sick patient population. And what we see here, amazingly, is that these patients really did very well. The median progression-free survival, you can see here, was 19.4 months. The median overall survival, 24.6 months. These patients really were doing quite well despite being very heavily pretreated. And if you look here, this is a subgroup analysis looking at brain metastases. And again, it's a very small subgroup, only 24 patients who had CNS disease. But you can see that the overall response rates were similar to the rest of the study, 58.3 month response rate compared to 60.9 in the general patient population. And then the response rates were the same, but also in terms of how these patients responded, they also did very, very well. So a 91% disease control rate in the CNS subgroup, 54% partial responses. And the median progression-free survival, again, in these patients with CNS mets was 18.1 months. So these are tiny numbers, but really, really promising in terms of the potential that this drug might have for patients, even who are at the highest risk for progression and death. So this drug, again, was also approved, and this is for metastatic HER2-positive breast cancer for patients who have received 2 or more prior anti-HER2-based regimens in the metastatic setting. So really a great option for patients as well. And this table shows data from the August 2019 data cutoff, which is what was initially presented, and then the June 2020 data cutoff, which was presented this year at San Antonio, and really kind of continued to bear out these excellent results. Let's talk about NALA very briefly. This is another study looking at neratinib, which we already talked about in the adjuvant setting, and this is looking at neratinib in the metastatic setting. So this data was first presented several years ago, looking at neratinib plus capecitabine versus lapatinib plus capecitabine in patients who had received 2 or more prior lines of HER2-directed therapy. They looked at a number of different outcomes, including progression-free survival, but also time to intervention for CNS disease, and also overall survival and response rate. And you can see some of these outcomes here, and we'll dive into them further in the coming slides. What you can see here is that with centrally confirmed progression-free survival, neratinib and capecitabine performed a bit better than lapatinib and capecitabine. If you looked at patients with CNS metastases at baseline, you can see here that these patients actually did quite well, a little bit better with the neratinib combination in terms of progression-free survival, 7.8 months on the neratinib arm versus 5.5 months on the lapatinib arm. And then here you can see overall survival about a 1 month difference between the two without a statistically significant p-value. This was a San Antonio update from this year, looking at CNS progression-free survival and time to intervention for CNS disease. And I think really interesting that CNS progression-free survival was longer in the neratinib capecitabine arm here. Again, this is small data and a little bit experimental, but 12.4 months versus 8.3 months. So more to come from this, but again, showing that this may be an active option for these patients. And the main side effect that we see with neratinib, and many of you may have seen this if you've used it, is diarrhea. The control study is a specific study looking just at diarrhea and how we control it in patients on neratinib. As you can see here from this San Antonio update, patients who receive sort of more creative treatments for diarrhea, not just loperamide, but also things like budesonide and cholestyramine if needed, really have very low treatment discontinuation rates related to diarrhea. So lots of promising options, not just for treatment, but also for symptom management, so we can help these people not only live long, but live well. Finally, the phase 3 SOPHIA study, also worth thinking about. This is a study looking at margetuximab. So this is a novel drug designed to alter Fc gamma receptor affinities, increasing affinity to different variants of the CD16A receptor. And we know that about 85% of patients, at least that were on this study, may have alterations in that CD16A receptor that could make them less responsive to trastuzumab. So this is a study in patients with second to fourth line treatment. So again, a relatively heavily pretreated patient population, looking at margetuximab plus chemotherapy versus trastuzumab plus chemotherapy. And the chemotherapy was at investigator's choice, as you can see here. The primary endpoints being progression-free and overall survival, and then a number of different secondary and exploratory endpoints. And this drug eventually gained approval based on this study, and is indicated in combination with chemotherapy for patients who received 2 or more prior anti-HER2 regimens. They did contain a warning on the drug here for left ventricular dysfunction and also for infusion-related reactions. That was really the main thing with margetuximab that was very different between margetuximab and its competitors, was that we see more infusion reactions with this drug. But these are manageable, and I think the most important thing is knowing how to handle them. So the progression-free survival benefit in this trial was a 0.9-month progression-free survival benefit. It was statistically significant, but I think some wonder a little bit about the clinical significance of that. Overall survival, we saw at the second interim analysis, there was a difference of almost 2 months. But then looking at this interesting planned exploratory analysis by genotype, again, 86% of patients in this trial had this altered CD16A genotype, and there was a 4.3-month median difference in overall survival. So again, I think this data, we still need to explore it more, but suggesting that margetuximab could be potentially a good option for patients who have those Fc affinity alterations, as we develop sort of more robust ways to look for these. So lots of advances made, lots of things coming down the pike. As you can see here, it's really a good time to be treating HER2 positive disease because we have a lot of different options in the first line, second line, and then as you can see here in the third line and beyond. And then looking forward, I think there are a lot of different opportunities that we're going to be able to explore and potentially put into place in the years to come. So margetuximab, we will certainly hear more about. We're going to be looking more, I think, at sort of immune therapy and how we can utilize that in HER2 positive disease. PIK3CA inhibitors, which we've already seen approved in ER positive disease, are also being looked at in this setting. And then CDK4/6 inhibitors, particularly for patients who have ER positive, HER2 positive disease, seeing if we may be able to use those to prevent resistance from developing to trastuzumab-based and endocrine-based combinations. So I think lots of different potential opportunities, and I think we will see outcomes continue to improve for these patients. So with that, we'll conclude. And I know that we would be happy to take questions if people have them via email after this program. And thank you so much for including us.